Jaundice is yellowing of the skin, and this is because of bilirubin accumulation. This can be from either the free bilirubin or conjugated bilirubin building up. When we talk about hemolytic disease of the newborn, or HDN, the fetal red blood cells are having a high turnover rate. There's more red blood cell hemolysis than synthesis. The baby's liver and spleen are still transitioning hematopoiesis, of course, to the bone marrow. So now you have this high turnover, and the liver is, just simply put, outmatched. The liver cannot handle that workload. It's supposed to be making red blood cells and transitioning that job to the bone marrow, and now on top of it, the poor little hepatocytes are supposed to conjugate the bilirubin. So in jaundice of the newborn, the yellowing of the skin and sclera, it's from an accumulation of unconjugated bilirubin. In the case of obstructive jaundice, this is now a problem with bile ducts. They might be closed due to portal hypertension or a gallstone. The formation of conjugated bilirubin is fine. That's normal. The problem is getting rid of it through the bile duct. So now the person will present with jaundice, and it's from the conjugated bilirubin. Again, in this case, their feces will be clay-colored and their urine will be a bright orange, reflecting an increase in urobilinogen. That's shown in this picture. A bruise is another perfect application of red blood cell destruction. A bruise is an ecchymosis, of course, and the initial color is from the tissue macrophages phagocytizing the red blood cells. As they are doing this, they release the unconjugated bilirubin, and in the tissue, the unconjugated bilirubin can be converted into a type of bilirubin called biliverde, which means green. That's part of the reason why you get to see this nice green hue of your bruise. And as it turns more yellow in color, that reflects unconjugated bilirubin, and as the yellow fades away, it reflects the unconjugated bilirubin finally entering the bloodstream and will ultimately be converted to conjugated bilirubin by the liver. Polycythemia is an increase in hematocrit, an increase in the number of red blood cells even. There are three ways a person can present with polycythemia. The first one I want to address is relative polycythemia. Relative polycythemia is a problem with dehydration. It's a problem with volume, not red blood cell synthesis. You see, I'll remind you that hematocrit is a ratio. It's the proportion of red blood cells compared to the whole blood volume. Well, if you have dehydration or you have reduced plasma volume, then that means your red blood cell column that you measure is going to be divided by a smaller number. Your whole blood measurement that you take is going to be this smaller height in column. Therefore, the relative proportion of hematocrit is going to seem larger. Certainly, we would not want to bloodlet this person in this case. Rather, the proper treatment is rehydration. Secondary polycythemia, I'm jumping to the right of the screen, is secondary to something else. It's usually reflecting compensation or an adaptive response. For example, we see secondary polycythemia when people move to a higher elevation. At this point, the kidneys are detecting a decrease in oxygen content and they're releasing EPO. So EPO is typically increased. We certainly would not bloodlet these people. There's a reason for their polycythemia. Another example of secondary polycythemia, and a great one, would be pregnancy. The parasite that the mother has embedded in her uterus is, of course, taking her oxygen, and her kidneys are going to detect this reduced oxygen content and increase the amount of EPO. I have to tell you, that was one of the first things I noticed when I was newly pregnant with my boys. Early on in that pregnancy, that little parasite really takes your oxygen, and you notice that. You walk up a simple flight of stairs and you are gasping for air. In striking contrast, polycythemia vera is a stem cell disorder. It means that the stem cells are replicating and dividing aberrantly rapidly. This means hematocrit goes up, but also total white blood cell count and platelet count goes up as well. So total volume of the blood goes up. Now, if there's more red blood cells and more oxygen carrying capacity, then that means the kidneys are going to detect higher than normal oxygen. And as a result, they're going to release less EPO. It is the level of EPO that can help us discern between polycythemia vera and secondary polycythemia. With polycythemia vera, the treatment is to bloodlet and add isotonic saline solution. Now I'm going to start to talk about the anemias, and there are many to talk about. To start out, we are going to focus on this true, strict definition of anemia. It is a condition where the blood has an abnormally low oxygen carrying capacity. This can be from low hemoglobin concentration and or because of low blood cell count. Now, why are anemic individuals often short of breath, fatigued, and chilly? Anytime there is reduced oxygen carrying capacity, this can provoke dyspnea, which means air hunger, and the person feels short of breath. Fatigued obviously because of reduced oxygen content. They're not getting enough oxygen to the brain, so they feel very sleepy. Chilly because formed elements, of course, the more you have of them, the more heat retention there is. Therefore, someone who is anemic, let's say from blood loss, they're going to feel cold. There are two broad categories or ways to get anemia. There can be a deficiency in the red blood cell production, or there can be blood loss. Blood loss can be further categorized into two subcategories, hemolytic or hemorrhagic. Hemorrhagic has chronic and acute underneath of it. Hemolytic means there is profound cell lysis. This can be acquired from exposure to venom, drugs, or an incompatible blood transfusion. Or this can be an inherited disorder that leads to rapid blood cell loss, like thalassemia, sickle cell disease, hereditary spherocytosis, and G6PD. In the deficient red blood cell production, the bone marrow is having a problem releasing sufficient quantities of red blood cells. I'm going to go through each of these, and as I go through the slides, I'm going to try very hard to match the slide header with the same color box as what you're seeing here on this slide, so you can mentally keep track of which column we're going into. I'm going to start out with the deficient red blood cell production, specifically iron deficiency. Iron deficiency frequently occurs in children. I'm sure many of you can identify with the fact that they are very, very particular about the food they eat. They're not really so big on eating the green leafy vegetables. And you know what? It's not just children that can have iron deficiency, but also women who are pregnant, where that little parasite that they're pregnant with is taking a lot of her iron for the parasite's own blood supply. Anyone who has chronic blood loss, let's say a bleeding ulcer, can also have iron deficiency anemia. In fact, most iron deficiency anemias are caused by or seen in a person who has a chronic hemorrhage. But like I said, there are some exceptions, like children and women who are pregnant. Iron deficiency can also occur if we're talking about a woman who is having heavy menstrual flow and has a low iron diet. Maybe she's not keen on eating her green leafy vegetables. When we look at red blood cells that are made when someone has iron deficiency, the cells are hypochromic. Right away you should be thinking this is reduced MCH. The cells are microcytic. Right away, again, you should be thinking of reduced MCV. And the cells are poikilocytotic, which means they have an abnormal shape to them, not that typical nice biconcave disc. When we put all these together, when we think of MCH divided by MCV equals MCHC, we recognize that MCH has gone down, and MCV went down too. But in this case, the mean corpuscular hemoglobin has decreased far more than MCV. This means we have a very small numerator divided by a bigger number in the denominator. Again, all these values go down, but the MCH goes down significantly more than the MCV. This would mean that we would have a decreased MCHC. One of the signs we would see in a person with iron deficiency anemia is the presence of mouth sores, because the mucosa sloughs off, and also your patient will likely complain of a sore throat. When a person is iron deficient, the most superficial layer of the epithelial cells, they slough off because they're not getting adequate amounts of oxygen. And that sloughing off of epithelial cells leads to the sore throat and mouth sores. Other symptoms that a patient might report is pica, which is an abnormal craving. You might see kids eating dirt, for example, or someone craving the act of chewing ice is another one. There are many, many others, but that's an example of pica. Still under the deficient column, deficient red blood cell, another type of deficiency in red blood cells is aplastic anemia. Now with aplastic anemia, you should understand that this is bone marrow failure. What would EPO levels be like in a patient with aplastic anemia when the bone marrow is failing? Of course, we would have significantly reduced hematocrit, but EPO levels would be very, very high. With aplastic anemia, not only are we going to see a reduction in hematocrit, but we're also going to see a reduction in white blood cells, platelets, all the formed elements go down in number. We will notice petechiae and infections due to the low white blood cell counts and low platelets before we likely detect the anemia. Therapy is a bone marrow transplant that is histocompatible, antibiotics for the infections, and transfusions. The cells, red blood cells, what few are made, are normochromic and normocytic. In the top right, you see a picture of bone marrow in a patient with aplastic anemia. Again, one side is showing you normal, it's on the right, and the picture on the left is showing you the person with aplastic anemia. The blue dots that you see for the normal person represents nuclei from stem cells. You can see there are many more stem cells on the right than the left. Primary aplastic anemia is idiopathic. We're not really sure what causes it. Secondary aplastic anemia can result from exposure to drugs. Some antibiotics, for example, people have an adverse reaction to them. When they have this adverse reaction beyond of what we would normally predict, we say that this is idiosyncratic. Antibiotics like chloramphenicol can cause aplastic anemia, as well as exposure to benzenes, radiation, etc. We also can have the stem cell being suppressed by the immune system. We can have malignancy in the bone marrow, commandeering the hematopoiesis sites. So lots of ways to have secondary aplastic anemia. I want to make sure that I make a line between aplastic anemia and what is called hypoproliferative anemia. With hypoproliferative anemia, the problem is that the EPO levels are low. Because they are low, the stem cells are not replicating and dividing as much. This is not bone marrow failure. This is simply the bone marrow reducing activity levels because the stem cells are not getting EPO to stimulate them. We certainly, as I said before, in a patient who has renal failure would expect them to end up anemic due to these hypoproliferative reasons, a reduction of EPO. Megaloblastic anemias are also under the deficient category. In this case, it is a dietary deficiency in folic acid or vitamin B12. When it's a deficiency in vitamin B12, we call this type of anemia pernicious anemia. Both of these vitamins are coenzymes and are both required for the synthesis of thymidine. Thymidine is one of the 4 nucleotides that should be incorporated in DNA during DNA synthesis during the S phase. If we don't have enough of these coenzymes, then we don't make enough thymidine. Then DNA synthesis is halted, and instead, these premature red blood cells, instead of replicating and dividing, going through S phase and then mitosis, they stay as one large cell. These cells focus on synthesizing hemoglobin chains and assembling hemoglobin. So there are fewer red blood cells made, and because they can't divide, these cells are megaloblastic. They're huge. They're really large and irregularly shaped. They're poikilocytotic and they have very fragile membranes, which means they're going to get caught up in those reticular fibers in the liver and spleen all the more readily. And if we go back to our red blood cell indices, their mean corpuscular volume is increased. Obviously, they're megaloblastic. But they also have increased the amount of hemoglobin that's contained in the red blood cells. So MCH goes up. In this case, both values go up proportionally. Therefore, the MCHC stays the same. Again, this should be a mathematical equation. Let me explain for the sake of many of you who may not have heard of MCH and MCV and MCHC in physiology. So here's my analogy. Let MCH, mean corpuscular hemoglobin, the amount of hemoglobin in a single red blood cell, represent your score on a lecture exam. Let's say you get a 50. Let mean corpuscular volume, how large the red blood cell is, be represented by the amount of points your lecture exam is worth. Let's say it's worth 100 points. MCHC is a reflection of MCH divided by MCV. It's a proportion of solute hemoglobin to volume. Your proportion on your test, your percentage, would represent MCHC. So MCH divided by MCV equals MCHC. So you got a 50, it's divided by 100, you would have a 50%. Well, now let's talk about megaloblastic anemias. Let's say the exam points went from 100 to 200 possible points, and your score went up from 50 to 100. Now you have 100 divided by 200. These are both bigger numbers than the original ones I used, but the ratio is what? Still 50%. So that's the same kind of thing that we see with megaloblastic anemia. The MCH and MCV both go up, but proportional to each other. Therefore, MCHC, the ratio, stays the same. What is a coenzyme? A coenzyme is an organic molecule that is going to help an enzyme do its job better. An apoenzyme is an enzyme that needs a coenzyme in order to work. Frequently, coenzymes bind at an alternative binding site somewhere else on the enzyme. When they bind, they induce a conformational change, such that their official binding site for the substrate will now open up and the enzyme can perform its enzymatic activity. Watch the screen. I'm going to click through this for you. Here we have our coenzyme, like vitamin B12 and folic acid, shown here as a yellow circle. The coenzyme is going to bind to the apoenzyme, like that, and activate it. It's going to cause a conformational change in the binding site. Now, look at the little white circle within the black enzyme. See how small it is? I'm going to push a button, and whoop-bam! The binding site becomes bigger. Now, this means that the substrates are not blocked. They can enter the binding site, and the enzyme can do its magic and make the product. Folic acid and vitamin B12 both are important for thymidine synthesis. Without them, DNA synthesis is arrested, and then the red blood cells are fewer in quantity but larger in size. Folic acid comes from green leafy vegetables like kale and collard greens, super yummy. By the way, the season to plant those is right now for a harvest in winter. There's also a greater demand for these vitamins, by the way, during pregnancy. Obviously, because that little parasite in the mom is replicating and dividing DNA and cells very, very quickly, it's getting bigger and bigger on a daily basis, it needs more of these coenzymes. More cells need to be born. With a folic acid or vitamin B12 deficiency, this means that the baby has an increased risk for neural tube defects. Neural tube defects can range from anencephaly, where the cranial cavity does not close and no brain forms, to myelomeningeal cells, where some of the spinal cord and spinal cord coverings, the meninges, protrude out of the baby and into the sac, and we call this spina bifida. We have about a 6 to 9 month supply of folic acid in the liver. So who can present with folic acid deficiencies? Anyone with poor nutrition. Elderly living in retirement homes, a person who's an alcoholic and not getting adequate intake of folic acid, a person who has a problem with absorption of folic acid, say someone with sprue, non-tropical sprue, or celiac disease as it's better known. These people have a reduced surface area for absorption, and they also can have a folic acid deficiency. Some anti-cancer drugs can interfere with folic acid as well. Vitamin B12 is found in meat, dairy, and eggs. It too is necessary for thymidine synthesis. You also need to remember that the parietal cells in the stomach mucosa produce a substance called intrinsic factor. An intrinsic factor is absolutely necessary for the small intestine, specifically the ileum, to absorb vitamin B12. So someone who has had a gastrectomy, where they remove a portion of the stomach, might lose a good portion of their parietal cells, and that means they have reduced intrinsic factor. They would need to get a vitamin B12 shot for the rest of their life. Well, your liver can store 3 to 5 years worth of vitamin B12. We can't give them a vitamin B12 vitamin orally. Why? They can't absorb it. Why? They don't release intrinsic factor, so therefore the shot would have to be required. Other conditions that can lead to vitamin B12 deficiency include anyone with gastric atrophy, a person with poor nutrition, strict vegetarians, alcoholics again. In those cases, poor nutrition, strict vegetarians, etc., they would not have a problem with the parietal cells releasing intrinsic factor. They're just not getting daily intake of vitamin B12. Now we're moving on to our hemorrhagic column. We are going to focus on blood loss. With blood loss anemia from hemorrhage, we need to be mindful of acute and chronic. Now, if we're talking acute, we need to remember that the red blood cells that were made were fine. MCV is normal, MCH is normal, MCHC is normal. What's the problem? Well, half of them just dumped out on the floor or into the ocean because Mr. Big White Shark bit off your arm. Chronic hemorrhage, and you need to hear me on this one, is the #1 reason why a person presents with iron deficiency anemia. In other words, chronic hemorrhage will lead to a different type of anemia, iron deficiency. This is because the demand for new red blood cell synthesis is so high from the chronic hemorrhage, and the kidneys detecting hypoxemia, they release the EPO. The demand on the bone marrow stem cells is just so high that the intestines cannot absorb iron in enough quantity that's required for this boost in red blood cell synthesis. So it's iron deficiency that chronic hemorrhage will lead to. I want to talk about this plastic blood on the screen. Of course, we think about our military out in the field. If a soldier needs a blood transfusion, they need to get the soldier back to a clinic or hospital where they have pints of blood already stored. Well, obviously the soldier could bleed out between that time. So there is this development of plastic blood, and here's the thing. The plastic blood doesn't require refrigeration. You simply add water to it when you need it, and then you transfuse it into the patient. This was undergoing some clinical trials last time I checked, but I added the link here in case you wanted to read up on it. It's a lab that's found in the UK. Moving on to blood loss hemolytic acquired, the red blood cells you are making are fine. MCV is normal, MCHC is normal, MCH is normal. What's the problem then? Well, the red blood cells are spontaneously lysing. Why? Maybe you got bit by a rattlesnake. A lot of toxins from snakes and insects are hemolytic, which means they cause red blood cells to rupture. Maybe there are some drugs that the patient is adversely reacting to. That could cause hemolysis. Blood transfusions where the blood types were improperly matched. So you would have the recipient's antibodies in that case attacking the donor's antigens on the red blood cells. That's what you're seeing in the top right picture. As the antibodies attach to the antigens of the red blood cells, this will start the complement system, and the red blood cells would lyse. This is the same phenomenon that we see in hemolytic disease in the newborn, where the most clinically relevant type of hemolytic disease in the newborn is Rh incompatibility, where the mom is Rh negative and the baby is Rh positive. In this case, mom's antibodies against the Rh factor cross the placenta and enter the fetus. Now mom's antibodies attack fetal antigens and cause rupture of the fetal red blood cells. When someone has blood loss, either because of hemolytic acquired or blood loss because of acute hemorrhage, obviously we can help that patient with blood transfusions until their own bone marrow replenishes the lost red blood cells. I just want you to be aware of that when we give transfusion therapy, we want to make sure that we don't have any blood typing mismatching, because if that happens, we can cause even more blood loss through hemolysis. So after we give a transfusion, we're hoping that we didn't give a mismatch of the ABO blood types. If we did, we're going to see signs and symptoms very, very quickly. We're going to see sensations of heat along the vein where the blood is being infused, flushing of the face. The patient might feel chills or have a fever, tachycardia, increased heart rate, dyspnea, that's the air hunger I was telling you about. But there can be other less severe blood transfusion reactions, some that are less sensitive. When we give transfusions, we want to collect the urine from the patient to make sure that we are not seeing any products from hemolysis that is arriving in the urine. By that I mean hemoglobin released from hemolyzed red blood cells and filtered by the glomeruli in the kidneys can end up in the urine. Two possible complications of a blood transfusion reaction are oligouria, which means no urine production, and renal shutdown because of the adverse effects of the filtered hemoglobin on renal tubular flow. The urine needs to be examined for the presence of hemoglobin, increased amounts of urobilinogen, and red blood cells even, because as the filtration membrane becomes damaged after the transfusion, we can actually get the filtration membrane being compromised, and red blood cells can really just leak right through it. So these are delayed hemolytic reactions, and they are of concern. They may be even 10 days after the transfusion and are caused by undetected antibodies in the recipient's serum. Of course, we're most oftentimes worried about ABO blood typing and compatibility, but there are other antigens on red blood cells that can also cause transfusion reactions.